So our next speaker is Dr. Monica Malec. Dr. Malec is an associate professor of medicine at the University of Chicago, section of geriatrics and palliative medicine, my colleague, and she is board certified in palliative medicine. Dr. Malec cares for all ages of patients with serious illnesses with a focus on oncology care. Dr. Malec serves on the University of Chicago's Pain Stewardship Committee and is a leading expert on pain management in older adults and end-of-life care. So please join me in giving a warm welcome to Dr. Malec.
Good morning, everyone. I want to thank the organizers for inviting me today, and thank all of you for coming in this morning to hear about this important issue. I am going to address the question. We might need to remind me a little bit as we get through the presentation that was just asked, because I think that's really important as a system-wide issue of how we go about addressing that education. But what I really want to talk about, you can tell from the title of my slide, Opioids and Pain, Good Intentions Gone Wrong. And I think what I really want to do is take a look back at how this emerged from a clinician perspective, from a generation of physicians who were educated in a way that I think as addiction professionals, you'll probably be like, really, you believed that? But from our perspective, this is what we were learning, and we were learning it from very knowledgeable, well-known, in our world, famous people that, really were convincing. So looking at what happened, so I went to medical school and trained in the late 80s and early 90s, where the attitudes towards pain and the attitudes towards opioids were really shifting, and our education around that was shifting somewhat as well. Now, I'm going to, our education around that, so I can tell you I got zero training about opioids in medical school. I'm not even sure that opioids were more than like one note card in my pharmacology class that opioids work at opioid receptors. So there was that. We did get a little bit of training, and then again in residency, I got one lecture about opioid management as part of a hospice lecture, and then as far as like addiction, zero addiction training in medical school, nothing. And then in residency, we were trained on screening for alcohol. Screening, and then asking, do you smoke? And then asking, do you use any other illicit drugs? As part of and that was it. So that was sort of the extent of the training that we got in addiction. And as far as like managing addiction or treating addiction, big black box. Here we are. So like I said, I trained in the the late 80s, early 90s. That was sort of early in the palliative care emergence. And in the late 90s, I started a palliative care consultation service which was really charged with managing pain in the hospital, both malignant and non-malignant pain. So that was just sort of this broad, we need this problem in the hospital fixed, and we would like your service to fix it. So I was seeing a lot of patients with chronic pain as well as malignant pain. So we really have to look at sort of uncontrolled pain is where this really started. And I think we can see from this, this is the International Association for the Study of Pain definition. So this is sort of the widely accepted definition of pain, and we can see that this is a sensory and emotional experience. It's a complex experience that people are going through. It can be for many different reasons. Those are sometimes very hard to tease out because people who have serious chronic pain often have depression because they've had chronic unremitting pain. So it can be very difficult to tease those things out, and I think we have to always keep sight of that. It's an exhausting problem. And then So we think about pain as, pain is a whole experience. So it starts at the center with a sensory nociceptive problem. And it's layered. And then we have the cognitive experience of pain. What am I feeling? What do I think about it? And the affective suffering aspects of it. I am suffering as a result of this. And then that comes to this place of the illness behavior, which is really that illness pain behavior. And I'm going to talk a little about this a little bit more when we would talk about some of the things that we were taught about pain. And the appropriateness or inappropriateness of those pain behaviors. But one thing I would definitely like to kind of get out there is like sort of in the medical world, we expect some very specific kinds of behavior from people who are in pain. We expect them to look like they're in pain, but not be too emotive about their pain. So we have this win, like, because if you're too emotional about it, then you're being histrionic. If you don't look like you're in pain, well, then you're not having pain. This is, if I can say it again, this is a complicated issue. Our physiology of pain perception. So this really starts with your injury. And transduction. So basically, that's the conversion of this noxious stimulus into a nerve impulse that travels from those nerve endings to some second-order nerves to transmit that pain through your spinal cord, where there are factors that both escalate that experience and factors that come down from your brain and modulate that experience. And then it goes to your brain for where you perceive the pain, and all different areas of your brain are involved in that. Your memory, your cortex, your emotions, so that shapes that experience. All the way along, we have opportunities to modulate, but it's important, because if your brain wasn't connected to your body, you wouldn't know you were having pain. And so when we think about how we treat pain, that's a very important part of it. When I get to a little bit more about how we were educated, it was a little sidestepped. So in the late 90s and early 2000s, there was an abundance of literature that was emerging about the prevalence of pain in the hospital, uncontrolled pain. And out of the hospital, and the consequences of unmanaged pain and suffering. There was a big focus on how we are neglecting to manage pain in a large proportion of patients who are seriously ill and dying, but others as well. The biggest of these studies that sort of put this out there was not actually designed to look at pain prevalence, but it was the study to understand preferences and prognoses and preferences for outcomes and risks of treatment. That's a mouthful. It's the support study. So that's a very commonly sort of reference study. And that showed that 50% of conscious patients who died in the hospital died with uncontrolled, moderate to severe pain, as reported by their families. So that sort of launched this, we really need to be doing better. There was an Institute of Medicine report. There were all these, we need to be managing this better. And yes, this was people who were seriously ill, but that did get sort of mixed in to everybody else. Because then we looked at the prevalence of moderate to severe pain in other patients with other more chronic illnesses, so not necessarily end-stage illnesses, but more chronic illnesses, and we see that the pain prevalence is essentially the same as people who have cancer. So that was something that was trickled out there. It's like all people who have serious illness can have some element of very severe pain. As far as older adults, prevalence of pain in older adults from the pain measurement in the National Social Life Health and Aging Project looked at the presence, intensity, and location of pain in older adults and really saw that 67% of community-dwelling older adults reported moderate to severe pain for a majority of time during the previous, I think, 1 to 2 weeks of the surveys. There were no differences across the age groups in the experience of pain. We know that pain may increase in the last 2 years of life for a variety of reasons. But we also know that pain in multiple sites contributes to pain-related suffering and disability. So that sort of sets the stage for wanting to do something about it. We know that chronic pain is a very common problem, impacting more than 100 million Americans. We know that more than 50 million Americans are partially or completely disabled due to chronic pain. And we know that health-related quality of life is comparable to that of terminal cancer patients. And these are non-terminal patients. And we know that chronic pain is a significant source of suffering. And we know that suffering and the relief of suffering is a responsibility of medicine. We were very much taught that one of our jobs is to relieve suffering. We were not necessarily given a huge toolbox to relieve suffering. There's an aphorism, a very common aphorism, that is that our responsibility is to cure seldom, to relieve often, and to comfort always. And how do we do that? Enter opioids. Opioids are a class of drug that bind to opioid receptors in the central and peripheral nervous system and the gut. We have naturally occurring opioids called endogenous endorphins that bind to opioid receptors. That's why this exists in our body, and it's then why these other drugs have a site of action. And we know that binding to opioid receptors has an analgesic effect. The runner's high is real. Opioid receptors are along the entire route of pain perception. And opioids also act in essentially all the areas of the brain where addiction is impacted and where there are changes in a state of addiction. So why do we use them? They work. In a word, we know they're effective. No one disputes their use in cancer pain and end-of-life care. And there are more than 70 randomized controlled trials that show that opioids are effective for management of non-malignant pain. They're superior to placebo with a high level of evidence, and strong opioids are better than antidepressants or NSAIDs with a moderate level of evidence. But they do come with problems. And they were problems that were not adequately recognized and were vehemently argued against in our education. So if you take a look at this quote, this is from a peer-reviewed journal published in 1991. And I think it really speaks to how we were educated in the use of opioids and the inadequate use of opioids. This article really kind of points out this idea that somehow the existence of pain was believed to protect a person from addiction. And I know that seems crazy, but we believed it. We believed that opioids acted differently in the brains of a person who had pain than in a person who didn't have pain, so that if you were taking opioids for pain as directed, your risk of addiction was very low. And then this article was another one, same time frame, that really, I think one of the important looks at this was that this actually allowed for the discounting of dissenting opinions. That they were, more puritanical and judgmental and even uncaring. That if you were not willing to manage the pain of the people in front of you, you were turning your back on suffering And so, there was sort of a self-righteousness in, we have to do this for these people because we care and we're trying to help. And we were not getting, I can honestly say, we would educate the medical students and the residents and the patients. Your risk is low with this because that's what we were taught and that's what we believed. So how did this explode? Pharmaceutical industry influenced education, which I can honestly say that it probably starting to work with Share Network and look more closely at some of these things, I really started to get more incensed about that because it was pretty insidious. It wasn't just attending lecture or having a drug rep come to the office and talk to you about these medications. They did that, but it wasn't that. It was actually more like this. The foundation arm of Purdue Pharma, Partners Against Pain, put out massive pain education pamphlets to everyone, and they were out there. They were written by people that were very well respected in medicine. Some of those people have been on 60 Minutes apologizing. But I think that's, so, and this was our resource. These were our educational resources because those resources didn't exist anywhere else. And they funded them. And it was just a little funded by, Partners Against Pain, Purdue Pharma on the back. But we weren't really at a point where we were suspicious of that in any way. Because we had, these things were it sort of grew up. And then it was like, hey, there's this big problem. Hey, we have this solution. There were speakers bureaus. They made the slides. It was easy money. A lot of people did them. And they were, and truly well-known people in medicine, well-known people in pain. The speakers bureaus actually required that you used their slides and that you not deviate from their slides. Full disclosure, I was not on any speakers bureaus. I'm not that good at following directions. And opioids were promoted for all pain, not just cancer pain. They were FDA approved for cancer pain, but they were promoted for all pain. They were marketed as safe. They were marketed as long-acting opioids we were told long-acting opioids are less addictive than short-acting opioids. It made sense. Long-acting opioids they slowly release in the body. There's no peaks and valleys. The short-acting opioids spiked up and then they went down. And we believed this. It didn't, it made some sense. Physiologically, it made some sense. Neurophysiologically, probably not so much. So opioid prescribing skyrocketed, and opioid diversion and misuse skyrocketed. And I'm going to come back to that a little bit because there's more. There's the World Health Organization created the three-step ladder. I don't know if anyone in this room is familiar with the three-step ladder if you aren't a practicing medical prescriber. But the three-step ladder is the three-step ladder. It was started to address cancer pain management, designed in, I think, the mid-'80s, the initial one. But then this ladder was actually, then used for all pain. It was like, we can apply this to all pain, and we should. We should be applying it to all pain, cancer pain, non-cancer pain, all pain. And I think if you look at the ladder, one of the most important things is this ladder is the pain medication is chosen by the level of pain the patient tells you they're having. So if a patient tells you they're having mild pain, well, then you'd give them Tylenol or something over-the-counter anti-inflammatory medicine. If a patient comes into you and tells you they have severe pain, you're skipping all those other steps and just giving them a strong opioid. Because pain is what the patient tells you it is, and this is how you're supposed to be managing it. If the pain is severe, that's what you do. You don't have to go up it wasn't intended to really necessarily go up all the steps. It's like, you can start right there. So that happened. Then this happened. Pain is the fifth vital sign. A scourge of, I think, our generation. So this really meant that this was mandated by the Joint Commission in 2001. Pain became one of the reportable features of the HCAHPS, or the Hospital Consumer Assessment of Healthcare Providers and Systems. This is public reporting, and pain management is amongst the things. So patients can look online and see, like, how well does this hospital manage pain? And the questions about pain are kind of press ganey questions. Did the hospital manage my pain? Or did, which led, and actually the Joint Commission implementation really meant that pain assessment and management there were arbitrary numbers. All pain must be, if pain isn't below a 4, why isn't pain below a 4, and what are you doing? And I think that we've come to this place of recognizing that a 4 is not the same for everyone. For some people, a 4 is a 0, and for some people, a 4 is a 10. And we don't know, those numbers aren't necessarily that meaningful. They're meaningful to the person in the moment, but maybe they shouldn't be driving our prescribing. But it took some time to get there. But this really pushed everyone to be asking about pain and everyone to believing that they should not have any. Pain is bad. I should have 0 at all times, no matter what's going on. And, how do we manage that? What do we know? We know we have these effective medications called opioids that will make those pain numbers go down. And then we had this realization. It became really clear that opioid overdose deaths and increases in opioid prescriptions were increasing in parallel. There was a 200% increase of opioid overdose deaths between 2000 and 2016. And, that was pretty shocking. And I think for a lot of people, then you start, looking retrospectively, like, how much harm have I caused? And wondering about some of the patients. Like, my practice now is all in oncology. That's pretty intentional, because early in my practice, I was seeing patients with chronic pain, and I did find myself wondering back then, so, before 2005, what are our goals here? What's happening? We were taught if the pain is unmanaged, increase the pain medication, increase the opioids. And that there is no ceiling dose of opioids, that you can just keep going up and up. And the reality is that pharmacologically, that might be true, but physiologically, not really. There is actually probably an effective ceiling dose of opioids, and there's a dose over which, if it's not getting better, we should stop. And now we know that over a certain dose, the risk of overdose death goes up dramatically. So I think this, and this is a place where I think we as a generation of providers are really trying to unlearn a lot of things that we were taught, and relearn what we ought to be doing, and trying to get to the place where we are effectively communicating the risks to patients, and giving them all the information that they need to make an informed decision, but also making sure that they're not just terrified, because there are times that people really do need these medications. So we're really trying to find that balance in both policy and practice. I think, the CDC guidelines are fantastic. They actually give a lot of guidance and a lot of information about what we should address when we're considering starting opioids for someone who has chronic pain, or continuing opioids for someone who has chronic pain. Because always and never don't really belong in medicine. There's never a time where we always should, very few times where we're saying, like, this is always the right answer or never the right answer. And I definitely have patients. I have patients who've been on decent doses of opioids for decades and are doing well. And when their chronic illness is in more of I don't know if it's ever flow, but when it goes down, when she's not in exacerbation, we decrease the opioids, and when it exacerbates, we go up, and incredibly functional for the whole time. Not really will always tell me, people tell me that they get a euphoria from this. I wish I could get a euphoria from this every now and again, and I'm like, I'm glad you don't. But we now actually have people who are, stuck on these medications. They got started inappropriately in, the early 2000s, and now here we have them and they're stuck. They come in and now, like, I see them because now they have cancer. They've been stuck on these drugs for a really long time, and now they have cancer. And now where do we go with this? How do we manage that? And many of them do have they have an opioid use disorder. And you're in this place of like, okay, well, now they have a problem where they need these drugs. And now we're in a situation where we don't have a lot of room to move. And where do we go? So one of the things that we're trying to do to address this at the University of Chicago, so these are efforts that came through the Pain Stewardship Committee. Our Pain Stewardship Committee is a multidisciplinary quality committee that focuses on pain management best practices. So this was actually what to do with your unused medications. This is the answer to what to do with your unused medications. There are other ways to dispose of them, but this is the safest way, a drug take-back. There are now locked, they're monitored by the DEA, they are locked, they are kept secure. They're places where we tell our patients, bring back your medications. When we started this at the University of Chicago, in that first year, we had more than a ton of opioid medications returned. So what does that tell us? We were putting a lot more opioid out there than people actually needed. And this actually worked both to educate patients about the fact that many people, the source of their medications that they are misusing is a family member or a friend. It also tells people that most people aren't using all the medications that they've been prescribed. And one of the things that we know is first exposure is usually after a procedure. So the next thing we did was really look through pain stewardship at trying to help our providers decrease the amount of opioids that they were giving in those initial prescriptions, because we know that the longer the exposure, the higher the dose, the more likely you are to develop a problem. So what we did was actually develop a dashboard for the providers. It's a general dashboard that shows the number of, we call them opioid prescribed days. So it's the number of days that we've given a patient. We actually made a very conservative 30 morphine milliequivalents a day. So that's basically 1 Norco 6 times a day, which sounds like a lot. Doesn't it sound like a lot? We started, and people were getting more than that. So that's important to consider. What we wanted was for people to not give more than that, more than 7 days at that dose. We were looking to get those numbers down. Our average prescribing when we started was 7.59, and now the average, just feeding that information back to people and telling them, this is really what we think you should be prescribing, feeding that information back and telling them has actually led to a decrease to now under that. We've met our target and we're under that 6.82, and it continues to kind of go down. We balance that by looking at, what's the number of prescriptions written, and also making sure that we're not just causing people to now go to the emergency room because they're running out of pain meds and their pain's uncontrolled, or more phone calls or more refills. And we're not seeing that. So what we're really seeing, and what we're looking forward to, is to see if the amount of now that's being taken back is going down. But one of the things is, during the pre-op visit where these medications are given, they're actually told, one, how to wean them down after surgery, and also where to return the medication. So that's part of their pre-op education. Those calculations, those morphine equivalent daily dose, is now part of every opioid prescription in our order entry system. So people can actually see, because a lot of times people don't really realize exactly how much they're giving out. They're not necessarily doing the math and calculating it out. So it's right next to their, what they're prescribing. It says, this is this many morphine equivalents for this prescription. This is what you're giving people, because we know that we want that to be under 50. And we know that, over 100 is highly, highly risky. But for opioid naive patients, we want that much lower. And now we actually have plans underway for naloxone co-prescribing for patients that are at high risk. And we're looking to try to scale that and roll it out in the hospital in the very near future, so that when we do have patients that are on chronic opioids that are getting higher doses, we are making sure that they leave the hospital also with naloxone. People who are co-prescribed other medications that might make them at higher risk or have medical problems that make them at higher risk, we want to make sure that they all get naloxone when they leave the hospital, that they're all trained to use it. My personal belief is that we really should just sort of be flooding the community with naloxone so that, it's just around. And that people know how to use it so that they're aware. And I've actually relaxed my stance. I think the cancer patients should get it too. It just puts more out there. And we are, and then we're also looking to, we're creating cognitive order sets to actually help guide pain management for physicians, so that it's not that, so that there isn't this over-reliance on opioids. Because, there is this conditioning. If I give this patient this, they're not complaining as much, and they're like, yeah, this helps me, this was good. But what we want is for more sustainable pain management that's really more multimodal and best practice. So we're trying to help guide clinical decision making in the direction we want by guiding the orders and the thoughts with it. So this is sort of where I am with opioids and pain at this point. That to make any real progress, we really have to unlearn and relearn what we thought we already knew. And I think meetings like this are actually a really good step. And I think we continue to try to put that out there. I do want to answer the question that was asked before. So there is education for anyone prescribing extended release opioids. There are things called risk evaluation and mitigation strategies that we're required to do. And now the state of Illinois has actually mandated that we have to have opioid training as part of our licensure renewal annually. So our licenses are renewed every 3 years, but we have an annual requirement for opioid education. As part of those, there is actually information on what we need to tell patients. In my notes, when I give a patient an opioid, I have a dot phrase that tells them the risks. It tells them how to take their pain medicines, tells them what to do if they're not working, who to call, tells them not to take them any other way than as prescribed because it's dangerous and can result in death, and how to store them safely, to keep them locked, to keep other people in the house safe. And I will specifically talk to older adults about their grandchildren and children, because I think that is a significant risk. And we've actually had hospice patients that have had family members have had young children take the medication and have serious consequences. So we don't want that to happen, and it's devastating when it does. And litigation risk aside, because that's a risk for us kind of all the time, it's just the right thing to do. And I think that it should become standard practice. The information is getting out there. None of this ever gets out fast enough into the community. But one other thing we're doing is putting a patient-provider agreement into our medical record, and the patient-provider agreement is actually a shared decision-making document that talks about all that as well. So those resources are out there, and we're working hard to disseminate them system-wide for the University of Chicago. But there are forces working towards it, regulatory and otherwise. Thank you.
Question.
Hi. I'm an elder care social worker with a whole load of seniors, and I'm asking the tramadol question. Everybody I know has a bottle of tramadol, and the doctors have a mixed opinion. Is it addictive or not? What's real?
Tramadol is addictive.
Okay, I will let
it
them
is an
all
opioid.
Well, I understand that, but doctors are sometimes not willing to say so.
So, yeah, and I think part of that was that they reclassified hydrocodone as a Schedule II narcotic, and now tramadol is sort of tramadol and Tylenol with codeine are the two that can still be called in. They can still be refilled. So it's because of, I think because of the way it's regulated, it's deemed less risky. But that's not correct. I mean, it's an opioid, and there are people who run into trouble with it, and it's probably not any, it's equivalent in its dosing to some of the other strong opioids. So the idea that it's a weak opioid is really more fallacy and marketing than reality.
Okay, thank you. And I will also add that from what I see, that the seniors are becoming much more wary of painkillers.
Absolutely. I definitely have cancer patients. We have a lot of conversation about the reason to use them, the reason not to use them. And they're scared. Everyone is scared, and they really, and rightfully so. But there's definitely situations where we really want people to take the medications to be. I always tell people the idea of this is to make you more functional, not less. And we don't want you needlessly suffering, and we'll work together. And my philosophy is, least amount of medication necessary to do the job. We don't want to just escalate things up. We actually want to get things under control.
Here.
Hi, I think it's really great that you share how doctors are now being held accountable for how much they give a day. But I'm just curious, how's that standard being done with dentists? Because I had an oral procedure, and my dentist wrote me a prescription for Norco. And I said, no, I don't think I want that. And he was like, are you sure? And I said, yeah. He said, well, take the Norco, and I'll write you another script for Tylenol 600. And so I ended up with both.
So I think we only have one dentist at the University of Chicago. I'll talk to him. So the places that do have dental schools have, I was involved in a project with the University of Pittsburgh that targeted dentists as well for teaching and learning about opioids, because I don't actually know what dental schools tell them. I would think that probably, given how little we were taught, probably less. And I think, so I do think that it's, trying to get that information disseminated. But they're also licensed through the state, and so they're going to have the same education requirements as far as learning about opioids and what's safe and what's not. So I think it just, but I don't actually know how their dental societies are educating them at this point. But that is a significant source of extra opioid out there.
Hi, excellent presentation. I'm wondering, however, in your efforts to reduce the amount of opioids that are prescribed, have you considered referrals to a clinical psychologist who would be skilled in behavioral techniques?
So this is a constant conversation about how we get more pain psychologists. It comes down to resources. I would love nothing more than for us to have a cadre of people who could do this. We have them in the outpatient setting, and we do have. I refer people all the time in oncology to our psychosocial oncology providers for those kinds of therapies. It's really not widely available in the hospital. We have one for a whole hospital. Which is better than none, but the situation that we end up being in is trying to prove that the cost benefit of having that person is there, and so yes, we think about it and talk about it all the time and try to figure out how we get that implemented.